We are live.
Okay, live. This is Senate Appropriations, February 26th. We're going through FY26 budget proposals. And today, Department of Health. So I'll let you introduce you and anybody else for the record.
Thank you. Commissioner Mark Levine, Department of Health, and Megan Hope,
Financial Director, Department of Health.
So, Chair and I have already talked, and for those who need it and are new to the committee, this will be a bit of a quick breeze through who we are at the Department of Health before we tell you about the details of the budget. Call your attention to the mission statement, which is a new one for this year, but it's sort of along lines of the WHO definition of what it's all about to be healthy and have good well-being. So it's very broad and encompassing. Notice the values. In spite of the times we're living in, we still proudly lead with the values that have certain words that apparently some don't enjoy anymore. Just defining public health, this is really the 1.0 definition of public health, which is really, first of all, focused on populations, not individuals, as opposed to healthcare, which is something I did for a long time. It's one person at a time. This is population. And it's really the triad of preventing infectious disease outbreaks and epidemics, preventing people from having harm from environmental threats, and trying to promote good health and prevent chronic diseases, which are at least 80 cents on the dollar of what we spend in healthcare nowadays. Now, having said all that, 2.0 is considered to be paying attention to all the health-related social needs, because if you don't have housing, if you don't have access to wealth, if you don't have transportation or food security, you cannot be healthy. Those are healthcare in their own right. And then Public Health 3.0 incorporates health equity into the equation. And the health equity part, of course, is everyone having the same opportunity to enjoy good health. And we know that in Vermont, we're a very healthy state if you look at the average Vermonter. But if you start to look at the data, you find there are general, all across the board, disparities in groups that are more vulnerable, whether that be defined by race, gender or sexual orientation, disability status, socioeconomic status, you name it. This is called the Health Impact Pyramid. You'll notice that increased individual effort needed is the top of the pyramid, and increased population impact is the bottom. So as a practicing internal medicine physician, my career was mostly on the top three parts of that pyramid. A lot of individual counseling and education, which really work, but they can take a long time for an individual in terms of changing their lifestyle, improving on their tobacco use, etc. Treating chronic diseases, or doing what we call health maintenance, preventive medicine, giving people immunizations, having them screened for cancer, cardiovascular disease, doing early interventions for alcohol use or what have you. But public health really lives on the bottom two rungs the most if we're going to have an impact. So changing the context to make the default decision that an individual makes the healthy choice. So how do we do that? Well, we have a long history in the tobacco world here of increasing the taxes on tobacco, making it less appealing to people because it's expensive. We have a long history of preventing people from getting secondary smoke and cancer that way because we've regulated where you can smoke and where you can't smoke. You can't buy crackers anymore that have trans fat in them because they're even worse than saturated fats for cardiovascular health, et cetera, et cetera, et cetera. So those kinds of things are the way public health gets things done. Sometimes people go along with them just fine, and that's when we talk about the savvy state, Other times, people sort of say, you want to put a tax on my Coca-Cola or other sugary beverages? No way. And that's the nanny state. So the goal is to strike the balance where people actually can resonate with the decisions that are being made. And then the bottom rung is the hardest one, of course. It's impacting those socioeconomic factors that really define how healthy your population will be. Working on poverty, housing, education, all the things the legislature is working on seemingly all the time, but certainly this year. And I'm not going to go into detail in this slide, but these are places where you might actually find public health intersecting with what's going on in your community. So this is the structure of our department, and I'll go through each of these just to give you examples so you'll know where VDH and your worlds have come together and your lived experience. But it's built, of course, on that foundation of health equity. So starting with environmental health, you just showed me that picture that the other places are using of marshes and flooded out areas and what have you. Well, you know, climate change is unfortunately a big part of environmental health, though it's poorly subsidized from the federal government level, with about 1.3 FTEs in our department of over 600 people. Health hazards like PFAS in the drinking water, PCBs in the air in schools are all part of this lead program, whether we're talking about something we collaborated on, which was lead in the drinking water of schools, or whether it's something like the Healthy Homes program and lead-based paint in older construction. Family and child health is kind of the tradition of public health. It's always on that maternal child end of the spectrum, keeping kids healthy, keeping their brains healthy, letting them have the best chance as they're developing as a fetus, and in that first months or years of birth are really critical. And we do that through home visiting programs, through the WIC program, and a whole host of school health and adolescent health programs as children get older. Laboratory sciences and infectious disease, well known to people because they lived through COVID like we all did, but clearly COVID is but one of the infectious disease pathogens out there, and there's a universe of those, and we have a staff dedicated to that. We also have a staff dedicated to preventing people from getting sick from those, and that's our whole immunization program. And we have a public health lab in Colchester, which really does a lot of testing that you can't get from traditional labs, and that states often need immediately because of what's going on the ground.
That picture? Is that picture of the lab in Colchester?
Yep.
Is that the
That is, yes.
It's right down past Costco.
And didn't we just hear the cannabis just move? They have a new lab.
Cannabis testing, yeah.
In Colchester as well.
Yeah.
Colchester's the lab testing capital of Vermont.
That's the hub. Wow, who would have known? Substance use programs, of course, deal with anything from alcohol through to opioids and stimulants, etc. A lot of stigma addressing programs. The Vermont prescription monitoring system, which helped with the early part of the opioid crisis, which was prescription opioids being abused and getting people onto heroin, etc. Now that's a much less common pathway, unfortunately. People go directly to some of the bad stuff. But this division deals all the way from prevention to intervention to treatment to recovery. Local health is just to show you that we are a centralized health department, but we have district offices equitably distributed throughout the state, which is really the boots on the ground. It's not like states that have like New York or Chicago where they actually have their own health department. These district offices are part of our central office, but they are really critical because when we need to set up vaccine clinics, testing clinics, WIC clinics, all that stuff happens at the local level, and the critical partnerships which drive how public health gets its work done, that's where they really happen. Health promotion and disease prevention is that chronic disease prevention, all those things I referred to earlier. It also has our tobacco control program. And one thing it has that we don't hear about all the time, but that's actually worked on and succeeded in Vermont to a degree that I never imagined is oral health. We have a long way to go, but we've got a long way. And one thing I'm proud of is, in addition to the maternal child health focus of public health, I've been able to introduce a healthy aging aspect as well, because really it's the continuum of life. It's not one population versus another. Whether it's a pandemic, whether it's a flood or a disaster preparedness, whether it's a biologic threat, we have an entire emergency preparedness arm. You'll notice it also takes into account the EMS structure of the state. And then the words injury prevention. That's sort of like climate change, where we get a little less than 2 FTEs for something that's magnificent and magnanimous. It's like suicide prevention. It's falls prevention. It's working on car seats for infants. The list goes on and on and on, including substances and mental health things. Just to give you one flat picture, but we have a state Vermont emergency management, we have state level emergency operations center, but public health has its own arm of all of that. And then finally, to be good in public health, you need to rest on data, because if you don't have data and you can't have credible data, you're not credible. So we have a very large division devoted to data. And whether that's survey data, whether that's registry data, whether that's vital records, it's all in the same division. Requires a lot of well-trained people who can not only figure out how to collect it correctly, collect it in a way without bias, but also analyze it well, and show when it's significant or not. And just a quote from a former Surgeon General, which is so true. We do like to be in the background more than in the foreground, but we haven't succeeded at that in recent years, through no fault of our own. Now to the budget, but I'll stop there if there are questions on the sort of introductory part of the presentation.
There's no question.
Good. So, start with the piegram. It's really to impress upon you the fact that the dark blue is so small, general fund, 11%. And that the federal component, whether it comes through federal funds, as in the gold, or whether it comes through global commitment money, as in the turquoise, that's like the huge portion of our department's budget. When I started 8 years ago, our budget was about $150 million. Now we're $226 million across 3 appropriations. This budget is $11.2 million higher than fiscal year 2025 was. So that's a 5.2% increase. And these are the sort of take-home points. The current service budget is fully funded. We are proposing $6.5 million in funding for new activities. The recommended appropriation for substance misuse prevention programming is increasing from $3 million to $6.75 million, and you'll hear more about that in a sec. And the budget also recommends $2.8 million in new funding for substance use disorder treatment and recovery. So my understanding is, in other presentations by the agency thus far, this committee, as per tradition, isn't interested in every up and down.
Definitely not.
I'm resonating with you. So we're gonna move, I guess, to where we should start you.
I think we'll start with the yellow section.
Yes, okay. Yeah, the Office of Health Equity. So there is an Office of Health Equity. It has moved from the Agency of Administration to the Agency of Human Services. So that particular office is in the Department of Health. So this basic change is, I call it a technical adjustment, just funding going from one part of state government.
So there's a down of 350 somewhere else in the
In AOA.
Okay. Because there was some confusion, because in the BAA, there was money for the health equity, the grants, that was also just moving the grants from the AOA over?
That's right.
Okay.
I think we're done with this slide now.
And that's the only thing that's helpful, maybe there's a bill that also, maybe that's the
There's
confusion.
a bill gov ops that's trying to clean it up a little bit.
Yeah.
Okay.
Or maybe not clean it up, depending on your point.
Work on it. To work on it.
I like that technical.
My
term.
understanding is that the other bill is moving the statutory authority for where it lives originally in AOA to the health department, whereas these changes are moving the money in the position.
So that's following the money for it.
Right. Right.
So still kind of just technical changes, nothing
Yeah.
substantial.
Nothing exciting.
And I neglected to mention, we have 3 appropriations. This is the first appropriation in this administration. But I'm not sure this slide
Oh, yes.
requires us to say anything. So we'll move straight to our largest appropriation, which is 58% of our total budget, which is the public health appropriation. And it funds, other than substance use programs and prevention, treatment, and recovery, it funds most of the public health programs in our department.
When you pay overtime, what is that's just normal staff? Are you paying when they work over schedule?
So like for like a disaster response,
Oh,
emergency
right.
preparedness, pandemic response,
Okay.
those are the areas usually. Laboratory.
The next big substantive
Yes,
change.
so we're now on this part of the budget that looks at grants
On
and the operating expense.
your vacancy turnovers, I don't know if that's the same page, was that the page before?
That's page 23.
Which is a very low rate.
So this 442 is a normal rate, 442,000 for general fund.
We're assuming that that's a 3% vacancy rate
Okay.
across the agency.
Perfect. Okay, keep going.
So we're on the operating expense side. And,
Did you move
We
out
got
of
a-
office space?
and so we moved from Cherry Street to here, to Waterbury, to the Agency of Human Services campus. And so there's a reduction in rent costs for our former central office in Burlington, but the central office had to stay in Burlington. The district office had to stay in Burlington because that's where the district office is. So there's an increase in rental costs for them because they're in a new facility on Riverside Avenue because they couldn't stay in the Cherry Street building we were.
But overall, it's the same, pretty substantial savings.
Yeah. Because we vacated a huge building.
Yeah.
Which would have had a huge parking garage expense too. Okay.
Yes.
So I will go to the immunization program. Included in this very large budget is the state's vaccine purchasing program. So the cost increases that you're going to see are related to that program. We are what we call a universal vaccine state. So we have a Vermont vaccine purchasing program that basically purchases vaccines directly from the CDC, a federal contract, and then supplies them at no charge to providers throughout the state for all children and for all adults who are under age 65. Because the Medicare program is not a payer involved in this. It will be sometime, but not while I'm commissioner. The program itself is funded through fees that are assessed to health insurers who cover Vermont lives. And these go into a special fund that's used for the cost of the program. This was authorized by the General Assembly about 15 years ago. 16, and made permanent several years later after a pilot. But from a public health perspective, it's an important factor in achieving success that we have with high rates of immunization against vaccine preventable diseases.
And are the rates still higher?
So 94% of K through 12 students in Vermont are fully immunized.
And has it been about 94 for the past decade, or is it?
Maybe 95, yeah.
Right.
So slight decrease, but pretty good. Very good compared to some states. I will though draw your attention to the fact that there's a measles outbreak in Texas now, and it shows what can happen. You can have an average rate of 94%, and you can have pockets that are lower. And indeed, we have pockets in Vermont that are lower than 94%. There could be some that are 80 or 70%. So that is where the population might be susceptible to some of the diseases you're trying to prevent. But you won't have the whole state population susceptible in the same way and have an outbreak get out of control, so to speak. In the last decade, there's been expanded coverage in this program. So aside from the traditional kinds of things like MMR, there are now influenza, very expensive shingles vaccine, and COVID vaccine. If you're an insurer, this actually lowers your cost. And you have, because we get it at a better rate through the CDC contract, and you have less people getting sick because they didn't get vaccinated, so you're saving healthcare costs as well. And we have an immunization advisory committee that the insurers are part of, and they have a voice in the decisions that we make about what vaccines are covered, and they can look at the annual assessment rate for covered lives. So in here, this proposal includes a $1.8 million increase in special fund spending authority. The things that go into that increase are the new vaccines I mentioned that have been added, the most recent COVID-19 vaccine, and price changes and changes in the number of total covered lives. There's also been requested on here a $770,000 global commitment funding increase. If you're an adult on Medicaid, the program pays a per member per month assessment that is based on covered lives, and the cost of that is included in our budget. I think that's all I have to say about the vaccine program. So, unless there are questions, I'll move on to the Advanced Disease Directed Registry. So you may recall there's a law that requires the Department of Health to maintain an Advanced Directed Registry. We have a contract, a grant actually to the Vermont Ethics Network, and they have a contract with a registry provider, which is called the American Living Will Registry, for customer service and administrative support. The fiscal year 26 budget is $435,000 higher than previous, and the high, sorry, it's $435,000, which is higher than previous. And the higher costs are related to this American Living Will Registry, which has increased fees. It's also reduced customer service somewhat, so the Ethics Network is having to commit more staff time to that activity. But we're keeping the registry going. Okay. Then there's the next line, which is the removing of the opioid abatement special fund money pending legislative spending plan. We're talking $1,050,000. What this has to do with is the recommendations of the Opioid Settlement Advisory Committee has been to recommend that amount of money to the syringe service programs. In the 2025 budget, it was written in such a way that it said this should continue every year, presuming that the special fund from the Opioid Settlement Advisory Committee recommendations had that money in the fund. So it's now being recommended in that manner as it was prescribed. in the previous legislation, so we don't need to have it in our own budget because it'll be in a separate budget. And that budget is, Act
Excellent. Yeah,
119,
218, I believe.
H 218.
yeah, it's in both chambers.
Which is in
Yeah.
both chambers. This is one of the
Yeah.
sponsors.
218.
And so it will be in that bill. So it doesn't want to be duplicated in this bill.
Okay.
So those are the changes in the public health appropriation. Any questions before I move on to the substance use appropriation? Okay. We can skip the first slide because again, it's ups and downs that are not substantive. And now if we go to the grants major object in the substance use programs appropriation, the first thing you'll notice is a change in the amount and source of funds for substance misuse prevention programming that is funded by the cannabis excise tax. So the governor's budget is recommending to replace the current $3 million general fund appropriation fee, which we've been getting for several years now through agreements with the executive and legislative branch. That $3 million general fund appropriation for substance misuse prevention programming should be replaced with $6.75 million from a new fund called the Substance Misuse Prevention Special Fund. And section 312.4 of the executive budget language has the statutory changes required to establish that new fund.
Where's the money?
The cannabis excise tax. And it's been more lucrative than
So it's just,
was
it's because of
originally
the,
imagined.
it's just because of the increase. It doesn't change that
Well,
percentage, you know, that was originally. set.
no, in fact, it has a cap of $10 million.
Because when it was just getting started, we needed to put general fund in there to do the work, but now that the excise
You
tax.
don't need it, right. So this is what was always intended, though I think we may have gotten there faster than imagined. I'll leave it to you if that's a good thing or a bad thing.
Oh, it's a good thing.
So there's a fiscal good thing, and then there's a public health is a good thing.
Right.
But I'm not weighing in on it. But this is great news
Our
for
alcohol use is down.
Down, yeah,
Our alcohol use is down,
right, we're getting less money from the alcohol
Okay,
fund, but more from the
okay.
cannabis.
and
Right.
alcohol continues to be the biggest drug of choice.
It is still, you're correct.
Sports gambling also down, which is, I think, good for,
Down.
down from estimates. We haven't had a whole year to really set a
No.
baseline, but,
Okay.
yeah.
Interesting.
And we're not that good at
And
gambling.
we're not that, don't let them kid you, we're not that good at it.
No, but they are good at addicting people.
Yes,
It's a new,
well, that's my worry, but
yes.
that's their focus.
But whatever the news, this still is good news because,
Saves the general fund $3 million.
it saves the general fund money and, we'll be able to support programs now in every community. Scale up programs that have worked in regions of the state to be statewide. And we can meet each community where they are in terms of readiness.
Right,
Big issue. The other thing you'll notice on this slide is, as noted in the public health appropriation, you'll see we removed $1.2 million appropriation of the opioid abatement special fund. That was for recovery housing. And we, again, as an advisory committee, the opioid settlement advisory committee advised spending recommendations that included that 1.2 million. So that will be in the other bill we just talked about. So we don't want to duplicate again. And then there's a net transfer of 594,000 plus change to from global commitment funding from health to mental health. And that just has to do with pilot projects in the certified community-based integrated health centers, CCBHCs. We're just transferring that amount that we budgeted to pay for outpatient substance use treatment with the providers in the new program. And then the last thing is our newest, I think, yeah, is the three proposals for are termed the Continuum of Care Initiative from the Agency of Human Services. And they're sort of addressing interrelated challenges, some of them related to substance use, some related to housing, some related to the criminal justice system and justice-involved individuals. So in that sense, a more public safety directed proposal. So here, I have to sort of describe the continuum to you rather than just cherry pick the 3 items that are in the budget, because it's a much bigger scheme. I see we have time, but I'm not going to take 12 hours to describe this. We have done due diligence as a department and as a division of substance use to really look at our system and say, where are there gaps? Where are there problems? Where can we do a better job? Where can we expand things? Where should we be more creative and do something totally new? We do that every year because you've got to keep a step ahead of the pharmaceutical companies. You've got to keep a step ahead of drug dealers and the climate that you're in. So one thing we were hearing a lot of, especially from those who deal with justice-involved individuals, is that they seem to fail at a higher rate and keep recycling through the system. They often go to a residential treatment facility, graduate that facility, and then months down the road, people find that they're back in the same cycle again. And really felt like we could do a better job of trying to prevent what becomes a relapse in their chronic disease of substance use. The reality is, most people in treatment in the state of Vermont are in outpatient treatment through the hub and spoke system and through intensive outpatient arrangements with treatment providers. But I would say maybe a quarter or so are in an inpatient treatment setting, which we call the residential treatment settings. So difficulties getting into those settings, sometimes difficulties where we or those in the justice world feel that an alternative to a sentence or an incarceration could be getting involved with treating the disease that precipitated whatever crime is being evaluated. And so trying to pave the way in. So the Department of Corrections has some items in its budget which deal with things like pretrial supervision and trying to ensure that people have this alternate pathway if that's felt warranted by those in the justice-involved world. We want to make sure that at the level of the residential facility, the pathway in is smooth, it happens in a timely way, and that while there, it's successful. Now, there's been a perception that it's unsuccessful at times because people don't stay long enough. Part of that is felt to relate to Medicaid payments, and we've done our darndest to try to convince the world that it's not actually the Medicaid payments, it's the clinical decision-making around when a person no longer needs a medically managed withdrawal program as a high-intensity inpatient level experience. But that doesn't mean that they can't stay there longer and be treated at lower levels of care and still have the appropriate group counseling, individual counseling, acquisition of life skills, etc., that kind of program can provide. So without asking for this in the budget, we actually have transition mechanisms in place to get people in. Stabilization beds or re-engagement beds, which is the first item there, that acknowledges that we don't have sufficient recovery beds all the time for people to get into, so-called sober living beds. So if someone's been through their residential treatment and are on medication for opioid use disorder and are getting counseling, and otherwise would have to go to an environment that they came from that would only foster the redevelopment of their disorder, These beds are meant to be able to be on stopover till the
Where are
recovery
these
bed opens up.
Where are these?
So a number of them are gonna be in the public immediate bed sphere. Others are gonna be in the mental health crisis bed
Are
sphere.
these like private
These are supervised beds.
providers?
Uh,
Like private nonprofit providers?
yes,
I don't remember the exact providers, we can get back to
yeah,
you.
I'm not sure
So,
how to label them.
Yeah, I've been talking with, folks about
I
this
know
as
you
well.
have.
We have a bill in there, and so, right, so is it going to be in the northern part of Vermont? Or is it going to be in Springfield, or is it gonna be in St.
It's not
John's?
gonna be a
Very-
new
It's
facility.
not gonna be it's them.
It's them,
It's
exactly,
several sites.
yeah.
So they are hopefully gonna be geographically.
How many beds
Yeah.
are you projecting?
A dozen,
Yeah, I believe it was 15
15.
15,
is what I
Yeah.
remember, but again, we can
16.
double check and get back to you.
16.
And then you said it's not in the budget, but it is in the budget, or what? I don't
No,
understand. This $1 million.
this part is in the budget.
Yeah, okay.
But a lot of the other things I'm talking about
Okay.
are not, like, transitioning from a highly medically necessary level of care to a lower level of care. That Serenity House, for instance, in Rutland has already got beds that they've traditionally admitted to, either people stepping down from the high level or people entering at this lower level because it was clinically indicated. And they've now added 16 more beds on their own. And we're hoping the other treatment provider in the residential arena will take that up as well. Once you're already, after weeks to a month or two of being in the residential inpatient setting, you still deserve to be in a recovery bed. Certainly to not go back to a setting that might be adverse for you. And that's why the next item is aftercare navigators, because that transition is really a place where people can fall through the cracks. And people who are more justice involved have a higher rate to fall through the cracks because they have a whole bunch of demands on them that we put on them, whether it's connections with DCF or connections with other parts of state government, in addition to continuing to get well from their substance use disorder. So aftercare navigators will be employed by the residential facilities and provide that safety net, if you will, and catchment for the transition to the next stage, whatever that may be. The hope is the next stage is a recovery bed, and that's where the next part of the proposal is. The recovery campus concept means recovery beds for housing, transportation to, and ability to obtain intensive outpatient treatment for your disorder, because it doesn't end just because you left residential treatment. And then on a campus, the ancillary services you're going to need to get yourself on your feet again. Whether that will be eventual connection with more permanent housing, whether that will be something like higher ability and workforce training and getting you back into the workforce in a productive career. All of those things that are lifestyle and life skills trainings, for lack of a better term, are all part of the proposal. And so basically we've got the 1 million for the re-engagement beds, the 320,000 for 4 aftercare navigators, and then a base appropriation of $1.5 million and a one-time startup appropriation of $500,000 for the pilot recovery campus. And we think that will address the gaps in the residential treatment system, particularly for justice-involved individuals, provide the stable and sober environment to facilitate recovery. And the estimate is that that amount of money will fund a campus of 15 beds. We have a total now of about 112-ish beds across the state. Plus there's a new site opening within the week or month of March. which will have, an additional 8 beds. We still will need more, but this is again, an ongoing process, that we hope will work. So there's the one-time 500,000, which is for getting the campus up and running. There's the 1.5 million, which is really supporting the people on the campus. And that's the end of the new part of the presentation.
Okay.
And we just have a summary slide, but I hope I haven't confused you, because my goal was to be as clear as I could be with what we're trying to propose in this whole continuum, and why only some of it you'll see on the budget request angle as opposed to the whole idea.
Megan, did you want to say that?
I was gonna say, I misspoke, the 15 beds was for the pilot.
That's what I wanted,
Yeah, so we'll get back to you, we'll have to.
on the other
We're
bit.
talking about the
On
RFP.
other beds.
Yeah, okay.
Okay,
I think it's 10 to 12 in that range. Which should be sufficient, because they've been actually underutilized as inebriate beds, which is why they're so difficult to maintain, because you can't have a 24/7 workforce where people are in and out, a month, a couple times a month, or what have you. So that will help that problem a lot.
So it wouldn't necessarily require that someone be judicially involved. I mean,
No, it's not
a public-
required, but
no.
it's sort of tailor-made
It
for
will help with that. It'll certainly help with the revolving door issue.
Yes.
And so we'll definitely be looking at it in our committee.
I do.
Yeah, and we already started.
Yeah, no, I think that
It's good,
we want it to be.
yeah.
And it is, where people in the judicial system and people in the treatment system have identified that we can do better.
Yeah.
So this will represent that effort to do better. And I think it's a bargain myself.
Totally.
Considering what we spend on substance use and mental health, this is really not a lot of money for, I think, a lot of bang for the
a
buck.
major problem across the state for sure. Did you have another question, comment? Any other questions for the good doctor? Okay, anything else you want to tell us? This is your last time here, probably.
Probably. I don't know. I mean, I'm still around all of March, but I'm not sure I have to come to this committee again.
Yeah, well, we'll have to find a reason.
I might have to come
Find a reason.
you're gonna come into my committee then.
Definitely. I would be shocked if I didn't.
Yeah.
Well, thanks for your budget
And
presentation.
I have plenty more I could tell you, but nothing you asked for, so.
Yeah, well, you'll probably have those conversations.